Vou começar a gravação aqui. Então, tudo certo, Orçário? Podemos começar? Perfeito. Então, hello everyone. Boa noite a todos. Buenas noches. My name is Felipe Almeida. I'm a 50-year resident of cardiovascular surgery here in Brazil, and I'm also the LACES ambassador of Brazil. And it's a pleasure to be here tonight with all of you. It's a pleasure to host this webinar. Before introducing our speaker, I would like just to say a few words about the webinar. This project is an initiative of the LACES Resident Committee, and we are doing monthly webinars with specialists and with great surgeons from all around Latin America. So tonight is the first time that Brazil is hosting a webinar, so it's very good to be here with all of you. And normally we do this in Spanish, so if you don't mind listening to the webinars in Spanish, you can join the next ones. The other countries are doing it in Spanish, but tonight, since we have lots of residents and lots of surgeons from Brazil, we're doing it in English, so everyone in Latin America can enjoy it. So Dr. Saadi, is going to talk a little bit about the TAVI, what does a young surgeon needs to know. And Dr. Saadi is a cardiovascular surgeon here in Brazil. He's also the professor of the Federal University of Rio Grande do Sul and the Hospital of Clínicas here in Porto Alegre, and also the chief of the Department of Cardiovascular Surgery and Structural Heart Diseases in the Hospital Mãe de Deus. Dr. Saad is going to talk about TAVI and what does a young surgeon, what does the residents need to know about this procedure. And if you want, you can join in the chat. You can text us the questions, and after the presentation, we're going to answer them all. So without anything further, I would like to let Dr. Saadi talk. Dr. Saadi, the webinar is all yours.
Buenas noches, muchas gracias, Felipe. Mi español no es muy bueno, so devo encerrar por acá e hablar, creo que melhor inglês do que portunhol. Then thank you
Sim.
very much, Felipe, for the invitation. It's a pleasure to be with all the LACES and to be invited by the Residents Committee of LACES to talk about a very interesting and important subject for all of us. So I will share my slides. Just please check if you can. Is it okay for you?
Yes, everything's fine.
Okay. So we are going to talk in about 20 to 30 minutes about TAVI, what a young surgeon needs to know, and then we'll have some time for discussion with which I think it's maybe the most important part of the presentation. I will change a bit the subject and the title of the presentation is not just what a young surgeon needs to know, but what a surgeon, independent of it's young or if it's not young. So this is my conflicts. So innovation in cardiovascular surgery, as you know, we started as a barber surgeon, and then we went to medical surgeon. Surgery was not a science in the beginning. It was a barber that used to do procedures. So it went into medical community just later on. So it's crucial today to have profound, a deep knowledge of imaging, as we are going to see later on. Endovascular and minimally invasive surgery are innovation, and we should be involved in this sort of innovation. Technology is getting better every day. Industry is investing a lot in the medical field, and we should follow and be updated to this new technology. So we should be able to do a multidisciplinary approach and patient-centered care in order to offer the best treatment quality to our patients. So imaging today is crucial. So CT scan, we should ourselves know how to read and to interpret the CT scan. We should not trust the radiologist or the echocardiographist from a report. We should read ourselves and understand deeply the CT scan, the transthoracic and transesophageal echo. Fluoroscopy, we should have also a very good knowledge of the projections of the fluoroscopy and to do a correlation between the imaging modalities, especially CT scan, echo, and fluoroscopy. As surgeons, we have probably a better understanding of the three-dimensional aspects of the valves, as many more than any other specialty, because we are used to imaging, we are used to see the valve directly, and we can understand better if we study the multimodality imaging to be the ideal operator, as we are going to see later on. So what would be the ideal steps for surgeons to be involved in transcatheter intervention in valve disease or structural valve disease? First, experience with conventional cardiac, aortic, and some major vascular surgery, as axillary artery or femoral artery exposure. This is all we have in a good 5-year training residence program in Brazil. Now we go straight to cardiovascular surgery residency without the need to do general surgery before. So in 5 years, we can do many of the most common cardiac operations and understand the imaging and treat as well experience with catheters, sheath, and guide wires. As interventional cardiologists, they do here in Brazil 2 years internal medicine, 2 years clinical cardiology, and 2 years interventional cardiology. So they are clinicians, they are not surgeons. And they have experience with catheters, is that all right? But with small catheters, with small sheath, and mainly to treat coronary arteries. So everyone that would like to go into this field of structural heart intervention, especially TAVI, should be familiar with these large bore catheters and sheath. So familiarity with imaging, as we spoke before, experience with femoral, axillary, and retroperitoneal vessel access. This is still now one of the most common complications of TAVR. Access is one of the most common complications. And if you know how to deal first to avoid this complication, to expose the vessel, know how to approach it with echo and with vascular closure device, we can prevent most of the complications, and when needed, we can treat the complications. So some experience in the endovascular surgery of the aorta would be ideal, because it's TVAR, or thoracic endovascular repair, is a very easy procedure. You should just have one access for the endograft, another arterial access for the angiogram, and it's just to put one wire and open the device to treat the thoracic aneurysm with an endovascular repair. So this would be a very easy beginning for the cardiovascular surgeons to go in this field of transcatheter treatment of structural heart disease. And now we have many, many pathologies that we can treat with transcatheter, as TAVI, PFO, ASD. We have transcatheter edge-to-edge repair with MitroClip, now Pascal. There are left atrial appendage closure. There is leak closure. Now there are coming mitral valves, transcatheter mitral valves, and transcatheter tricuspid valves as well. And we will see this in our near future. So we started doing our measurements for aneurysm repair like this, with a printed method and a very archaic measurements. So now we have access to like a workstation of the CT in our own notebook. So it's just all we need is a Mac, a notebook, or a desktop, and then we can import all the images in DICOM format, and we can reformat. We can do a multiplanar reconstruction, and this is useful for all the aortic disease to treat aneurysm. This is very important for planning TAVR, and this is very important to plan valve in valve and most of the interventions in structural heart disease, like left atrial appendage closure, for example. Of course, in some cases, we will need other methods like echocardiogram, but we should know, we should learn, we should deeply dive in the evaluation of the CT angio. Fluoroscopy is very easy. There are not many projections. For example, for TAVR, there are just two projections, and we can plan these projections in the time of implantation the day before. Usually, with the transcatheter therapy, we plan and we do the procedure the night before. Uh, at the time of the procedure, we just execute what we have planned previously. So these are the two main fluoroscopy projections. One is called three cusp view. Is this view that we usually deliver balloon expandable valves like Edwards Sapien, and you can see here the non-coronary sinus, the right coronary sinus, and the left coronary sinus in a coplanar view. This is called cusp overlap view, where you isolate, usually in the right and caudal oblique projection, you isolate the non-coronary cusp on the left side of the screen, and you overlap the right cusp anteriorly and the left cusp posteriorly on the screen. So this is for TAVR, but we should know for any other pathology that we are going to treat by catheter, the correlation of this projection with CT scan and with echocardiogram. This is a huge aneurysm. As you can see here, is a 3D reconstruction. The imaging methods today are very, very nice, and we can reconstruct it very, very easy. So the first CABG, as you know, was done in 1967 by René Favaloro at that time at Cleveland Clinic. And since now we had several new procedures. And with new procedures, we have also new devices. So endovascular aortic surgeons started in 1991. I would say like a bit more than 30 years ago. Percutaneous valve implantation, the first case was done in 2002 in France, and the first case in Brazil in 2008. So this is quite a recent procedure. Structural heart correction of other diseases are also very common now and will become even more common. So we should be involved. We should also be involved with minimally invasive and even robotic surgery. Of course, you need a special training and you need volume to develop confidence in these areas. So a new area of surgery is a hybrid surgery. It can combine conventional surgery and endovascular. This is used for aorta, for example, and used for coronary. Sometimes there are centers that are doing robotic lima to the LAD and then putting stent in the right and circumflex artery. So every new training, we need a new environment and we need an open mind to learn new things. There are no doubts that transcatheter interventions change the paradigm in the last decades in the cardiovascular medicine. In general, there is no need for anesthesia, just local anesthesia with slight sedation or even no sedation. No need for intubation, no need for mechanical ventilation. The trauma is minimal. We have no incision, we have just punction, and we have vascular closure device that we can close the femoral arteries, the axillary artery, and even the carotid artery, just percutaneous with one or two perclose. And there's a rapid recovery, which patients are paying more attention in the time they recover to go back home and to go back to work. So we should not try to fight with these new techniques. What we should do is try to learn how to do and to selectively decide which procedure is the best for a specific patient. So, what is the current scenario in cardiovascular surgery? There is an historical dominance of conventional surgery. Of course, we were all trained in the OR, doing big operations, doing dissections, doing aortic aneurysm, doing CABG, doing valve replacement, valve repair, doing heart transplantation. So surgeons are very conservative. We take a long time to be good surgeons, and we are not very keen to move from one side to another. Once we have learned to do one procedure, it's difficult to convince a cardiovascular surgeon to do it in a different way. So surgeons are conservative. This is problem number one. Problem number two, there are just a few specialized transcatheter therapy centers in Latin America. There are no specific training center for transcatheter therapy. And this is true not just for cardiac surgeons, but also for interventional cardiologists. We are just starting to settle these centers, and we don't have a formal training in transcatheter therapies here in Latin America. And these are starting as fellows in the US and Europe, And I think we are going here in the same way, like fellow training in transcatheter therapies. Another interesting thing that we notice is there are many residents that when they can choose be in the OR doing a big operation or going to hybrid room or cath lab, they prefer to stay in the open surgery. I think now things are changing, but we have both training in our service here in Porto Alegre, and in the beginning they preferred to stay in a cabbage or a AVR or another open surgery than go to an endovascular treatment of an aneurysm or a TAVI or a mitral clip or I don't know why, but maybe they think it's more interesting and more challenging to do open operation than to train transcatheter, which is no doubt simpler than open operation. And of course, as we trained our conventional surgery very, very carefully, we require new skills, not only catheter manipulation, which is crucial, but we should understand imaging. We should be have proficiency in imaging. And if you compare here now surgeons and interventional cardiologists that came from the clinical side, I have no doubt that we as a surgeon, we have a much better understanding of the pathology that we are dealing with. So this is a very nice image. You can see this is a 3D echo. It's like you are seeing the valve in an operating room. So transcatheter aortic valve implantation. Here we have a SAPIEN valve, balloon expandable, just a punction on the femoral artery with one or two perclose. Here we mount the balloon on the valve on the descending aorta. Once the balloon is mounted on the descending aorta and we have crossed the aortic valve, we just advance the valve through the aortic arch and then cross the stenotic aortic valve. There are sometimes we need pre-dilatation, but usually in balloon expandable valves, we don't need pre-dilatation. So we adjust here the valve. There's a mark on the balloon right on the middle of the valve, and we inject contrast, and we should keep the valve 20% in the left ventricle and 80% in the aorta. You see, when we inflate the valve, it comes from the left ventricle to the aortic annulus, and then all of this, the sizing and everything, is planned previously by the CT scan. Then we remove the sheet and we tie the ProGlide, the perclose that we have inserted percutaneously. So when we are talking about indications, we should always think on the disease and a patient with a disease, not just a disease. Aortic stenosis is very different if a patient is in their 60 or if a patient is in their 80s, and depending on the anatomy. So the guidelines says here, European guidelines, that TAVR is preferred, is recommended for patients more than 75 years of age if there's good anatomy for a transfemoral TAVR. And open surgery, conventional surgery, is recommended for patients less than 75 years. In the American guidelines, TAVR is recommended above 80 years. And open surgery less than 65 years. And there's a gray zone between 65 and 80 that we should consider some anatomical points. And here, the patient's opinion and the patient's decision. So this is very, very gray zone because patient's opinion depends on what story we tell the patient. Sometimes when we tell just the beginning of the stories and not the end of the story, sometimes they can decide for the wrong operation. So I'll call your attention for this. Less than 65 in the US is conventional surgery, and less than 75 in Europe is conventional surgery. Here is class 1A in the American Heart Association, American College of Cardiology, that for patients, symptomatic patients with less than 65 years or life expectancy more than 20 years, surgery is recommended. This is what the guidelines says. What happens in the real world? In the United States, about 50%, half of the patients less than 60 years old are having TAVR now in the United States. So this is completely against any guideline because they are usually listening what the patient wants, and obviously that you always choose the less invasive treatment, but if you have comparable results. So I will show you now a clinical case, and then we can discuss what you are going to do with this patient, and I'm going to show you what we did. So this is a 66-year-old male patient with severe aortic stenosis, with shortness of breath. He had a previous PCI. His STS is very low, 1.8%. He's not frail, and he has normal renal function. This is a usual echo of aortic stenosis. It's a tricuspid valve with a mean gradient of 47 and a valve area of zero point 0.9 squared centimeters. You can see here there's a hypertrophy of the left ventricle and a very calcified aortic valve with a high velocity. So, of course, when the patient goes to our office, this is the first thing they usually say. We prefer the less invasive. There's a quicker recovery, and in this patient, there's a coincidence that we had implanted a TAVR in his father at the age of 84, and 2 days after the procedure, he was at home and he's very is fine now. So the patient saw his father recovery, and so he prefers TAVI. So what we say to the patients, you have a severe aortic stenosis and you need to treat it. And the patient said, wow, what should we do? I prefer the less invasive. So we will discuss the pros and cons. So usually the patient say, I don't want surgery, I want TAVR. What are they really asking for? They want a low risk procedure. They want to minimize the number of big procedures during the lifetime. So the first assumption is that when you do one procedure and you go well, this will function forever. And this is not true. We know that there are no biological valves that last forever. So this is his coronary angiogram with the stents okay, no stenosis. So what to do first with this patient? First, we should do an angio-CT. first before deciding anything. And we should know how to measure all uh, the measurements that are needed for TAVR. This is a plugin that we have in our computer and will take 2 minutes to do all the measurement. You can see here it saying what we have to do. Click on the base of the right, adjust the coronary cusp, click and draw the annulus ring. So they are going, this process plugin, they are telling us what to do. So this is what to do when we see a patient with aortic stenosis before deciding which type of intervention we are going to recommend for him. So this is a report, is a very quick report. You can see the calcium here, you can see the S curve here, you can plan your projection, you can see how the aorta is horizontal. You put here the calcification, cusp, LVOT, annulus calcification. If you go for TAVR, you choose the axis, and now you can generate a PDF report with all the data, and you can save this in your computer. So this is the first thing we should do. So imaging angio-CT is crucial to define the anatomy of the valve, if it's tricuspid, if it's bicuspid, the height of the coronary artery, the angulation of the aorta. Here you can see 61 degrees, the size of the aorta, the left ventricular outflow tract, the amount of calcium. So we should not decide anything before having an angio-CT. And we should read the angio-CT ourselves. Here you see the very nice access, small tortuosity, but no calcification and big sized vessels. So in this 66-year-old patient, what we are going to do, TAVR, let's say that biological valves last for 10 years in a 66-year-old patient. When he's 76, he will have to do another operation. We do SAVR surgery with a biological valve. We put a mechanical valve that he needs anticoagulation. We can do minimally invasive surgery, mini sternotomy or right anterior thoracotomy. The point here is that all the patients should have an angio-CT before deciding. Well, you know very well that there are some advantages in terms of durability of mechanical valves, but the main drawback here is that they need anticoagulation with rat poison forever. So when the patient is old and he needs anticoagulation, most of the patients, they don't like to be anticoagulation. And when they are old, they don't like to have anticoagulation. It's not good. And biological valve is good, but the problem is that there's structural heart degeneration. So in this patient, 66-year-old, previous CABG, previous PCI, sorry, what we decided to do, a biological valve, a mini sternotomy. So if there's problem here, 10, 15 years later, we can do valve in valve, which is a very safe procedure. We have some advances, some technology advances in surgery as well. This is an Inspiris Resilia from Edwards that comes with this sort of possibility to increase the size in the future, and it comes almost ready for a valve in valve with marks, even with the number of the valve marks, and with this possible expansion that we can expand this valve one size more than we have implanted. So we have good options to decide which one is better for each patient. There are plenty of literature comparing surgery aortic valve replacement with TAVI. And it started with extreme risk there in 2010, then high risk, intermediate risk, and now 2018 low risk patients. In almost all of these studies, they demonstrated that TAVR is non-inferior to surgery. But I'll have to point out some gaps that we have to put a transcatheter valve in a younger patient with more uh, life expectancy. Bicuspid valves, we don't have evidence that TAVR is equivalent to surgery. We have more AV block and permanent pacemaker. Mild aortic regurgitation by paravalvular leak is more frequent in TAVR. Coronary access is sometimes a problem depending on the valve you choose. And the big problem is durability. If you put one valve in a patient, a biological valve, and the patient have a life expectancy more than 10 years, probably you have to do another procedure. And this is what we call lifetime management. That when we do the first procedure, this will have impact in the whole life of the patient. Because TAVR in TAVR is a more complex and more risky procedure than putting TAVR in a native aortic valve or putting a TAVR in a bioprosthesis, a biological surgical valve. So life expectancy and lifetime management is very important when we decide the first procedure. We know that the Achilles heel for all biological valves is structural heart deterioration, and this is true for surgery, and this is true for TAVR. This is the partner 3, which is the low risk study by Edwards, that in 5 years there's almost no difference between surgery and TAVR for patients with low risk. But as you can see here, the curves, surgery is yellow, tends to cross in about 3 years, and then there's a trend towards a better result in terms of total mortality in favor of surgery, but this is not statistically significant. Just now came out the 10-year result of the partner 2A. These are old patients, intermediate risk with a mean age of 80 years. And you can see here, in 10 years, there's a mortality of more than 80%. So in both groups, almost all the patients are dead. So it's very difficult to take any conclusion from this study because we started here with a patient on their 80s, and 10 years they will be on their 90s. So the mortality is high, and it's very difficult to take some lessons from this study. But I would say that the result is the same for TAVR and aortic valve replacement by surgery. This is the only randomized trial that included patients with bicuspid valve. It's called Notion 2. 26% of the patients in this study had bicuspid valve. And as we can see here, the primary endpoint was worse in the patient with bicuspid valve than compared with patient with tricuspid valve. So we should be careful when indicating TAVR in patient with bicuspid valve. And why is that? Here you can see a very nice picture of a bicuspid valve. You can see the calcification is very different. There's always a raphe, a calcified raphe, and there's usually a horizontal aorta. And it's not just about the size of the aorta. It's going beyond the size. Our colleague from Brazil, João Cavalcante, which is in Minneapolis now, doing a very nice job studying bicuspid valves and flow dynamics. And here we can see that a patient with bicuspid valve that had a TAVR, here is a SAPIEN 3, and you can see that the flow pattern in aorta, here is bit dilated aorta, it goes to the outer part of the aorta. And here we can see as well that the flow dynamics is not in the middle of the aorta, but it goes on the side. So there's increased risk of dilatation and dissection if you have an aortic dilatation associated with bicuspid valve. So in this patient, especially young patients, we should be more prone to indicate surgery than TAVR. This is the only study that compares valve durability in 10 years. There are many valves here that are not used anymore in surgery and even in transcatheter. But what we can see here in Notion is that the all-cause mortality in 10 years is almost the same for TAVR and surgery. You should prepare for this. Here in red is valve in valve. I mean TAV in a bioprosthetic valve degeneration, surgical valve degeneration. These are US data until 2021. This is much higher now in the last year. And here is TAVR in TAVR. So we are going to face every time more patients with degenerated TAVR, and we should know what to do. This is a big problem because when you have a TAVR and you put another TAVR inside this TAVR, you will create a conduit that has more possibility to occlude the coronary arteries. If you put the valve too low, you have what we call leaflet overhang. And there is stenosis of the first TAVR, you still have stenosis. And you can have a leaflet deflection as well if you put a valve here. You can see here where you transform here in the covered stent, and all of this part here is covered by the previous valve and have a high risk of coronary occlusion. This is one case, one example where you see the coronary artery is above the valve. So this is a case that we can do a TAVR in TAVR. This is a case where the frame is very close to the coronary artery, and here is a frame much closer to the coronary artery that if we put another TAVR here, this coronary artery will be obstructed. So when we do the first procedure, we should think that if this valve fails, if we can do another TAVI in TAVI, or if we have to explant the TAVI. And explant the TAVI is a procedure that is becoming extremely common, and it's not an easy operation. It's a new problem that was created. And Gilbert Tang and Vinay Bapat did this explant registry, TAVR, and you can see here that in-hospital mortality is 12%, and 1 year mortality is almost 30% when you have to explant a TAVR. So if you tell a patient that you are going to do the first procedure and put a TAVR, and the second procedure you replace this TAVR for a biological valve in a conventional surgery, you should tell them that the risk of a redo explant TAVR is very high and much higher than usually open aortic valve replacement. This is a case we did 10 years and before. 10 years after, had the problem with the TAVR. Here you can see the generator TAVR, mean gradient 87, aortic regurgitation. Okay, we decided to do another TAV in TAV. It was possible. We put an Evolut inside a Sapien. You see here the coronary is okay, but the patient now has 70 something years, and when she has 77 or 80 years, what are we going to do with this? Probably we are not going to be able to put another TAVR here because the coronary will be obstructed. And how about doing an open operation and taking out all of this in the patient near their 80s? So we should take this into account. So it's very important. In the first procedure, we plan and we try to preview what is going to happen if this valve fails. Now we have simulation, we have AI, we have several tools that can help us to predict if we can do a safe TAVR in TAVR or not. So this will influence our first decision. So some take-home messages. TAV in TAV for index TAVR failure will become increasingly common in the next decade. And there are not all the patients that will be suitable for this procedure. Explant TAVR is a risky surgical procedure with high mortality, and you, as young surgeons, will face this new challenge and this new operation, especially if you have a high frame TAVR with the frame very incorporated with the endothelium of the ascending aorta. Sometimes very difficult to remove this TAVR, and sometimes it's necessary to do a root replacement. The first procedure is very important in the lifetime management. There are different TAVI devices, and meticulous CT and fluoro planning is critical in evaluating TAV and TAV feasibility, especially on coronary obstruction risk. And maybe the most important take home message is that we, as cardiovascular surgeons, we should be involved in all forms of treatment of valve disease. And why is that? Because we treat these valves, aortic valve, mitral valve, tricuspid valve, pulmonary valves, we treat these pathologies for decades. We know the natural history of the disease. We know when to indicate intervention. We know the anatomy and the physiology and physiopathology of valve disease. We know imaging. We should dive more deeply in imaging like CT and echo, but we know the imaging that frequently we do our operations with TE, but we should try to learn transthoracic echo and transesophageal echo as well. We know how to treat these valve conditions with several types of surgery, one more complex, other less complex, but we know. And we know, very importantly, how to treat the complications, that they are not all the doctors that knows how to treat complications, especially if you have an access complication, if you have a pericardial effusion, if you have a dramatic complication like an annulus rupture or a coronary obstruction. So if we have all of these qualities, why not to treat it by transcatheter? We should focus on training. We should try during your residency, and if you were not able to do a training during your residency, try to go to a center to see first and then to be involved in the treatment of valve disease by transcatheter methods. Here is an invitation. We are going to do, we are three surgeons here. We are involved in all forms of treatment of transcatheter structural heart disease. And we'll do this event for the third time, which is called TVI, Transcatheter Valve Intervention, here in Porto Alegre, Brazil, November 5th from 7. We'll have hands-on, we'll have live cases, seven live cases from the main centers of the world. And we'll be very happy to have you all here. And we'll talk to Felipe and to Rui, which is the LACES president, to give you a good discount to come and visit us in Porto Alegre and learn a bit more about transcatheter valve disease. So thank you very much for your attention. I'll be quite happy to discuss this subject with you.
Thank you, Dr. Saadi. It's always a pleasure to hear your talks. and I'm amazed by it. And it's very nice uh, to see a meeting about TAVI where the main case, the answer is not TAVI. It's very good to see that us as surgeon, we have all the tools that we need to treat the patient in the best way. We are the only specialists that can offer all of these different procedures to our patient based not only in the age, but the risk, and as you told us, the lifetime management of the aortic disease. So it's very good to have all of these tools in our disposal. And it was a very nice talk. I would like to ask one question as a resident, and you told us that the residents sometimes they prefer to go to the operation room instead of the cath lab to see the TAVI procedures. And do you think it's possible during the residency to be trained as a kind of a hybrid surgeon, one that can do open surgery and transcatheter, or do you think that you should first focus on operating open surgery, and after your residency program, you should go and do a fellowship or maybe go to a big center and train in transcatheter?
Well, Felipe, I think it's possible. I think the main limitation is that there are just few centers that in the surgical field, in the cardiovascular department, you have both of alternatives. Here in our center in Porto Alegre, we do both. We do open surgery, we do heart transplantation, we have heart failure, we do transcatheter, and we do all the procedure. And now we are starting to do minimally invasive surgery. We used to do mini sternotomy for aortic valve replacement, but now we are doing mix for mitral and other operations as well. And the residents here, they are involved in transcatheter therapies. We have like 10 or 12 open cases a week, and we have a mean of three, sometimes five cases of transcatheter cases a week. So they can rotate and they can learn both of the procedures. But I know this is not the reality of most of the centers, as this is not the reality of most of interventional cardiologist centers as well, where usually they do just coronary. So I think that we should look for some places to spend some time, maybe at the beginning, a rotation or 1 month, and see if you like, because the learning curve of transcatheter is much faster than open heart surgery. We take 10, 15 years sometimes to do good operation and to be confident to do a coronary anastomosis if it's not a good vessel or so. And I can assure you that if you, as a surgeon, do a training with 6 months, 1 year, you'll be a master in transcatheter therapy, probably better than most of the cardiologists that train it. So I think it's possible. I think it would be the ideal world, but it's not what we have nowadays.
Okay. And but do you think it's possible for example, a young surgeon or a resident that have finished the residency to develop this kind of proficiency even in a low volume center?
Well, I think that the learning curve depends of the number of cases you are involved with. So I think the best way would be to spend some time in a high volume center of structural heart disease to reduce your learning curve. Because if you do one case and then you are going to do another case in 1 or 2 months, it's difficult to learn. But if you stay in 1 month in a center doing like 10 or 20 cases a month, then you take it much easier. And I can assure you that it's very easy to. We started here with the aorta in the late 90s, doing thoracic and abdominal aorta. We do carotid stenting, and we started to do TAVR here, one of the first of Brazil to do TAVR. So this is why we are involved. We were one of the first to do, but I know this is not the reality in most centers. If you can work together with an interventional cardiologist with a good relationship, this is an alternative. But there are many centers that is not as difficult to create a real hard team. There are some centers that they have a hate team, not a hard team. So if you cannot have a good relationship with your cardiologist, it's difficult to train in your center. But I think the ideal world would be the surgeon to spend some time in the cath lab and the interventional cardiologist spend some time in surgery. Of course, it's much easier for us to learn to do how to deal with catheters than for them to operate heart. But we are trying to design the best way to train people for transcatheter structural heart disease treatment.
Okay. And my last question is just a quick one. What's the most common pitfall or mistake that a young surgeon must avoid at all costs during training and after that during the procedure
You mean in transcatheter or
in
overall?
transcatheter? Yes.
I think the main mistake is to think that if you know the pathology and you know the valve, it's just go there and see once and do it, because there are no room for adventure. Transcatheter is not difficult, but you have to train it very, very carefully, the same way we train surgery. So we have to train how to do a very good punction. You have to know exactly how to put the vascular closure devices. You should learn imaging. You should plan your own cases, not trust in the company report or radiologist report. You should look at the CT, you should look at the echo, you should know exactly what is going to happen and have plan A and plan B, and how to deal with catheter, because we see some surgeons and some interventional cardiologists as well, they are not used to deal with the large bore sheet or with catheters, how to cross the valve, and what are the main steps, the drawbacks that you need to pay attention. So you have to do a complete obsessive training as the same as we did in surgery. So that the main difference that the learning curve is much faster in transcatheter than in conventional surgery.
Okay. Thank you. We have one question in the chat. It's from Guilherme Moraes. Good evening, doctor. I'd like to ask a question. We know that TAVI and other endovascular procedures are becoming increasingly common in the daily practice of cardiovascular surgeons and in residency training. However, most of these procedures are still performed on private or insured patients. And many of our attendings don't yet have the same level of experience and with endovascular techniques as they do with open surgery. As a result, the residents often have fewer opportunities to be actively involved in these cases. Given this transitional scenario, what advice would you give us as residents to make the most of our training and gain a solid experience in endovascular procedures as well?
Guilherme is from where? From Brazil?
Uh,
Where
I
are
don't
you
know, but
from, Guilherme?
see if he answered.
Because
From Brazil, yes.
yeah, Brazil, yeah. Here in Brazil, yeah, Rio de Janeiro, okay, Guilherme. Here in Brazil, we are just starting. Let's start with the aorta. It was the same journey that I believe is going to happen with all structural heart disease. At the beginning, the devices were very, very expensive, like $30,000, $40,000. Now, the devices for TVAR and EVAR are cheaper. and you can do it by the public health system in almost all the hospitals that are, of course, high complexity hospitals. So endovascular treatment of aortic disease is a routine in the public health system in Brazil. Now we are just starting to have the incorporation of TAVR in our public health system. So here at Hospital de Clínicas de Porto Alegre, we started to do TAVR with a partnership with the public health system about 6 or 7 years ago. And from 2 or 3 months from now, we started to do it straight from the public health system. So we are doing 8 cases a month now on the public health system, exactly with the amount that the government pay for the TAVR, which is total 57,000 reais. So the hospital uh, takes call several industries, and so they put them in confront to decide which one can do a better price. And we can do here with good devices like Medtronic, for example, in patients of the public health system. I know that this is not the reality of the most places and service that have cardiovascular surgical residence in Brazil, but I'm sure that in few years these are going to be the reality, because the changing paradigm of TAVR is even more than with treatment of endovascular treatment of aortic disease. So I think it's a question of time. And now what we can do, what we did, what when we started to do, is try to go and see in places where people are doing it is more routinely. So we always receive here residents from all over Brazil. We receive people that have finished their training to spend a period here with us. There are other centers in Brazil that also have a good volume of transcatheter procedures in their cardiovascular unit. So I think we have to help each other. There are no magic formula or quick magic carpet to go straight to be a good operator in transcatheter. But so far, I think we should try do to go to different centers and to change. For example, if someone wants to do pediatric cardiac surgery, we don't have pediatric cardiac surgery in our center. So they usually go, spend some time in another center that does pediatric and see if they like. So they go and they train. I think this is the now what we have to offer for the residents that are training in a center that has not the possibility to train in transcatheter.
Okay. Thank you, Dr. Saadi. Does anyone has have another question? You can send it in the chat. Otherwise, I think we're done for today. And it was amazing to be the first one to host this meeting here in Brazil. We had 50 participants here in our webinar, so I think it's a very expressive number. And yeah, I would like to. Oh, we have one more question before we finish. So,
No, oh yeah, okay. Okay,
hello,
because
professors.
I just put the link of the site here of the TVI, but let them wait a bit, Felipe. So you and Rui, we are going to send you a card with a discount for people that are LACES member. I think
Okay,
Amabile would like to make a question. How are you,
okay.
Amabile?
Maybe if you like, you can even join us. I open your microphone if you'd like to ask directly this question.
Hello, hello everyone. Hello, Dr. Saad. It's a good pleasure to meet you all. And I would like to know in this our context in now TAVI is increasingly being performed by cardiology elite, and I would like to know what the most important skills we should put our focus to remain essential members in the heart team, and because we saw situations um, that we have big problems in cat labs, and they call us, and I would like to know the most important the your tips to us to remain important.
Right. I agree, Amabile. I think that this is the main problem with most of the surgeons. They are not the main operators, and sometimes they are not even in the cath lab. And you are just called when there's bleeding on the femoral artery, when there's a pericardial effusion, or when there's an embolization of a device. Let's say that. So I think the first thing we should do is try to learn with our partners. I think that if you don't have a formal training, you know that you are welcome to come to our service and to learn a period with us. And I know you very well, all of you, you and Victoria and Thais are very good residents and you are quick learners. So we are going to learn it very fast. So this is point number one. Point number two, we should talk directly to the cardiologists. Once you are able to do conventional surgery, minimally invasive surgery, and TAVR, and there's no doubt that you will be the best doctor to evaluate a patient with aortic stenosis with the less bias. Because if you do surgery and transcatheter therapy, TAVI in this case, you should have the less bias. You can choose if the patient is 70 years old and is fit and there's no good femoral access, it's better for him to go for surgery. If he's 82 years old and has good femoral artery, there's no doubt that you do local anesthesia, put a TAVR, and is going home next day. So I think we should convince our cardiologists that we should evaluate the patients and then we decide which form of treatment is better for them. Because usually, if you don't do TAVR and they have a patient like in the 70s, they will think, I would send to interventional cardiology because he will have the less invasive treatment. But if you do both, he's probably going to send you the case so you can evaluate with the less bias. So this, I think, two tips: train and then do work as a gatekeeper. You should go to an office to have patients, to talk to the patients, to talk to the cardiologists. We prefer to be in the OR operating. I prefer to be operating, but 2 days a week I am in my office receiving patients from the cardiologist and talking to the cardiologist and explaining to the patient which method of treatment I think is the best for him.
Okay, so thank you, Dr. Saadi. Does anyone have another question? So, okay, I think we're done. Would you like to say the last words?
Just thank you and say that nothing is easy. Nothing is easy. We started here with aorta, and then we try to choose our best residents to work with us. We try to create the best team, not the people that are not going to be involved and have the best treatment, best uh, training. So Ana Paula, I think probably is here is listening us. She was interested in training after finishing her training with us here in Porto Alegre. She went outside Brazil in Switzerland and stayed there for a year and a half doing transcatheter therapies. Now there are other residents that are very good in training. Rodrigo did his training and had many opportunities during his training that our volume was higher as well. So you see that now we are three surgeons and we are organizing a meeting just on transcatheter valve. So this is a meeting for surgeons. Of course, there's not just for surgeons, but if you are interested, come and know people from all over the world so you can make contact, you can go there, you can visit, you can come here with us. I think this is the main thing I would like to finish this presentation. We collaborate. We should collaborate with each other because we are a small community and we have many difficulties in common. So let's try to make life easier.
Yeah, for sure. And you can always count with the LACE's Residence Committee also, Dr. Saadi. It will be a pleasure to also send this website to all of our residents in the Latin America. So maybe people from other countries can also join. And to everyone watching us, it was a pleasure to be here. Follow us on Instagram at latam.laces. And also don't forget to go to the Laces website and subscribe to be a member of Laces. It's free. It's totally free. You don't need to pay anything. And then you can receive the newsletter and the emails with all the updates and all the next webinars. We are going to have one webinar each month over this whole year. So it will be a pleasure to be with all of you again next month, maybe talking in Spanish a little bit more. But it's a good thing to all of us to know surgeons from all around the world. So again, Dr. Saadi, it was amazing to have you here, and thank you again for accepting my invitation.
Thank you very much for the invitation and good night for everybody.
Bye bye.
Bye bye. Thanks.